Good evening and welcome to tonight's webinar on mental health versus mental illness. For those of you who are new to CMHRC, my name is Elizabeth Errico and I am CMHRC's Executive Director and Founder. Our mission is to provide guidance and resources for early identification and management of mood disorders, bipolar disorder, and its newly identified phenotype that has been dubbed FOH by the researchers who identified it and its current treatment protocol. In order to fulfill this mission, we have a number of programs and services that we offer to families, mental health providers, educators, physical health providers, and they include our hands-on palliative parenting classes. They are offered face-to-face, live over Zoom with a facilitator, or in an on-demand self-guided video course. We also have our ketogenic therapy in action program, which is pioneering the use of metabolic therapies in order to treat mental illness. We also have our CMHRC toolkit, which is custom software that we developed for families and providers to use in order to track symptoms, medications, mood tracking. It even includes a place for narrative summaries, for a summary of the daily weather, sunrise, sunset, and all sorts of information that is essential if you are attempting to track the impact of medication changes and the use of other therapies. Our Wayfinder services are a high-touch, personalized support system that we have available for both providers as well as families, where we provide diagnostic support for families and clinicians in terms of honing in on likely diagnoses and or explaining the ramifications of a diagnosis to a family who does not have access to a healthcare provider. We also provide community advocacy and consultation so that we can reduce stigma and increase quality of life for those who are living with mental illness. And lastly, we have our interdisciplinary professional discussion groups that are available online, live over Zoom, where we bring together an interdisciplinary group of providers to talk about cases, gain peer support and supervision, and improve their mastery of mental illnesses, their presentation and treatment in childhood. In order to do all of this, we are a 501c3 nonprofit charity. It is 2025, and all year long, we have a fundraising campaign going on that we've dubbed Give 25 in 25. You can use the QR code on your screen to take you to our safe and secure online giving platform where you can set up a recurring monthly donation of $25 or make a one-time gift of $25. We ask that you consider doing this, especially if you take advantage of any of our free offerings, like our monthly webinars and clinical seminars, so that we can continue to provide excellent services to families, to providers, and to make as many of our resources available for free as possible. So I'll bring this QR code up again at the end, and we would love to have you become part of our family of donors. Now, tonight, we are going to be talking about the difference between mental health and mental illness. And this is very important because for years now, there has been a movement towards reducing stigma around issues related to mental health. And that has helped tremendously in terms of us being able to have a larger conversation about mental illness, which is wonderful. But the trouble comes in when we don't acknowledge that there is a difference between mental health and mental illness. And with our collective focus on mental health, it has meant that we have unknowingly sort of swept mental illness under the rug a bit. And it also means that we're not talking about or possibly don't even fully understand what mental illness really is. And so our learning objectives for tonight include 4 things. 1, that we are going to identify the difference between mental health and mental illness, that we're going to understand the prevalence and impact of mental illness on children and teens. We're going to review best practices for effective treatment, and we're going to learn about a new, more effective approach to parenting that supports parents and caregivers of children who live with mental illness. So first, to start with, we are going to take a step back and look at our physical health and physical illness as a way of framing the conversation we're going to be having about mental health and mental illness. So I'm going to start off with the definition here of physical health, and that physical health is a state of well-being when all internal and external body parts, organs, tissues, and cells are functioning properly, or as they're supposed to function. We all have physical health, and we all experience variable states of physical health, which can be challenged by external factors such as a cold or a flu or some temporary injury like a broken bone. After a physical health challenge, we return to baseline, and often there's no intervention that is required. Obviously, there would be for a broken bone, but you know the old adage that physicians use about having a cold, that if you don't do anything to treat your cold, it'll go away in about 7 days. And if you do something about the cold, it'll go away in about a week. This is not the case for physical illnesses. With physical illness, not everyone has a chronic physical illness. And for those who do, their baseline is one of a chronic state of illness. It includes involuntary symptoms, which cause subjective distress and impair functioning. So examples would include things like asthma, diabetes, heart disease, muscular dystrophy, cancer, and more. The thing about physical illness is that interventions are almost always required in order to maintain baseline. Now, we're going to ease into talking about mental health by talking about mental health versus physical health. So I'm going to bring up again this definition that we have of physical health that we've been through already. And we're going to add to it a definition of mental health. So mental health is a state of well-being when mental, emotional, and psychological factors function properly, or as they're supposed to function. We all have mental health, and we all experience variable states of mental health. Our mental health can be challenged by external factors such as loss, factors in our environment, relationships, and life changes. And after a mental health challenge, we return to baseline, oftentimes without the need for any kind of professional intervention. Okay, so now we're going to juxtapose physical illness and mental illness. So again, physical illness is something that not everyone experiences. It causes involuntary symptoms, subjective distress, and impairs functioning. And intervention and management is required long term. The same is true for mental illness. Not everyone experiences a chronic mental illness, and baseline for an individual who has a mental illness includes that chronic state of illness. This again includes involuntary symptoms, which cause subjective distress and impair functioning. And examples include diagnoses like OCD, major depression, bipolar disorder, ADHD, schizophrenia, and more. And importantly, just like physical illness, intervention and management is required for long-term stabilization and success. So now we're going to take these two definitions that we have and put them against one another in terms of mental health and mental illness. So mental health is a state of well-being. We all have mental health. It can be challenged, but when challenged, we are able afterwards to return to baseline, often without intervention. Mental illness, on the other hand, is not something that everyone experiences. And baseline includes that state of illness, which includes involuntary symptoms, subjective distress, and impaired functioning. Intervention for long-term success in managing a mental illness is required. So what I want to do is I want to take you to look at more closely something that is called a disorder, but is actually an example of a mental health challenge and not an example of a mental illness. And that is a disorder that is called adjustment disorder. And the diagnostic criteria for an adjustment disorder can be found in the DSM, and it includes this criteria: the development of emotional or behavioral symptoms in response to an identifiable stressor that occurs within 3 months of the onset of the stressor. The symptoms and behaviors are clinically significant, as evidenced by marked distress that is out of proportion, or a significant impairment in some area of functioning. The stress related to that disturbance doesn't meet the criteria for any other mental illness, and it's not merely just an exacerbation or an intensification of some other pre-existing disorder. The symptoms don't represent some sort of normal bereavement. They're not better explained by prolonged grief. And once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. Now, we refer to this as a disorder, which is confusing, when it actually is a challenge to a normal state of mental health and well-being. It doesn't mean it's not important. It doesn't mean it doesn't need to be supported and addressed. It just means that it is not a chronic long-term illness. And we know this because when we look at this criteria, we see 2 important things. One, that it has an identifiable stressor. We can all name identifiable stressors that can cause us to struggle with our mental health: the loss of a loved one, the loss of a job, moving across country, making a major change in a career or in an educational course, having something significantly unexpected occur, enduring and living through some kind of natural disaster. These are all things that we can point to and say, yes, that is something that is an identifiable stressor that can cause serious and important disruptions in our mental health. But the other piece that is so important is that once that stressor or its consequence has terminated, the symptoms don't persist. This is not going to be the case when it comes to mental illness. Mental illnesses that commonly occur in childhood and adolescence include all of the ones that are on this list: major depression, generalized anxiety disorder. Yes, bipolar disorder is something that occurs in childhood and adolescence, schizophrenia, DMDD, PTSD, borderline personality disorder, OCD, ADHD. This is sort of what we call the alphabet soup of the diagnostic process. And there are more, but we're not going to list all of them tonight. One of the main differences, though, between mental health and mental illness while a person is experiencing distress is that with a mental health challenge, the person who is experiencing that distress can likely still learn new skills, put those new skills into practice, and through that process, send symptoms into remission. This is what mental Health treatment modalities like cognitive behavioral therapy are designed to do. They're designed to teach the client, the individual, new skills, and then coach them through the process of putting them into practice so that ultimately they can utilize those skills when they are distressed independently and no longer need the intervention of treatment. The goal there is to incorporate those new skills into a person's normal way of functioning. With a mental illness, however, those symptoms are not just being triggered by some sort of identifiable external stressor. With mental illness, people are experiencing distress as a result of involuntary symptoms that not only do they obviously not have control over because they're called involuntary symptoms, but are just as, if not more, disruptive to their state of well-being and to their ability to function. And because those symptoms are involuntary, someone experiencing a mental illness episode is not likely to be in a position to learn new skills. They are not likely to be able to put those skills into practice, and they're unlikely to be able to access the skills that they already have or have previously learned when they are in a state of distress. It is just that simple. This can be difficult for a lot of providers, educators, parents, and caregivers to truly understand that previously learned skills may not be accessible during a symptom outbreak when an individual is experiencing the effects of an involuntary chronic mental illness, such as the ones I mentioned earlier. Now that we have these definitions in place, it's important that we talk about why it's a problem that there's a lot of overlap. And there is truly a false equivalence that is created when we talk about mental health. If you look at the headlines on the news in newspapers and magazines and online about mental illness, very often what you will see is you will see headlines and articles that are written and talking about mental health. When we talk about somebody who has a chronic mental illness, we very often use the term mental health challenges, mental health issues, mental health conditions. But the truth is that that is a false equivalence, and it damages ultimately the access and acceptance that people with mental illness have in our culture. And so I'm going to start off by talking about some pros of the false equivalence because there are some. The false equivalence pros are that it can reduce stigma and promote acceptance to be able to have these conversations. Maybe there are folks who won't read the article if it's headlined with mental illness. They think of that as being something for other people. But when the title of the article is about mental health, they're more open to hearing what the article has to share. It can also improve access to certain treatment modalities, such as cognitive behavioral therapy, which I mentioned earlier. And it can introduce the idea of mental illness, see there written mental health challenges, in a non-threatening way. Because the idea that we have challenges to our mental health, whether we think about it in that language or not, is a familiar one. But there are cons, as I said, to this modality. And that is that it minimizes the impact of that illness on the individual and their family because it makes the benchmark or baseline for mental health the one that is established by those who don't have a mental illness. This would be the equivalent of us expecting that anyone should be able to walk up a flight of stairs because people who have two functioning legs can do it. that cannot be the baseline for how we approach stairs. The same is true for mental health. The benchmark for mental illness cannot be one that was established by those who don't have a mental illness. Another con of this false equivalence is the impact that it has on medication and medicinal therapies, because it reduces the perceived acceptability of medication use. And again, this ties back to the idea of what the baseline is. If someone says, well, I lost my father and it was painful and I was very, very sad, and I got through that whole thing without taking any antidepressants. Therefore, I don't understand why people who are very, very sad and depressed need to take antidepressants. It is a false equivalence. And yet when we use language that does not identify the difference, we reduce the likelihood that those who need medication will find it to be an acceptable course of treatment. It also minimizes involuntary symptoms as expected human experiences. We have this disorder that we educate people on, the newly identified phenotype of bipolar disorder that is referred to by researchers as FOH, or fear of harm. It has had a number of different names over the years. Most recently, it was called thermoregulatory fear of harm mood disorder. Now it's currently called thermoregulatory sleep dysregulation disorder. But the name fear of harm became a flashpoint because people were saying, well, everyone's afraid of being harmed. How can that be a diagnosis? What are you pathologizing that's a normal human experience? Well, we're not pathologizing a normal human experience. What we're doing is we are identifying a major hallmark symptom of a disorder that is involuntary, has involuntary symptoms. And so being able to recognize that mental health and mental illness are not the same thing will help us accept that involuntary symptoms are not normal human experiences. Another con of this false equivalence is that it attributes intention and choice to those involuntary symptoms. The language that we use around this as a culture is pervasive. We use words like decided, refused, insisted when we are talking about involuntary symptoms of mental illness. Now, this is especially true when we're talking about children and teens, because there's a pervasive belief that children and teens should do what they're told. And when they don't, they are characterized as being difficult, oppositional, defiant, that they have a characterological behavior problem that is rooted in the fact that they are choosing, refusing, insisting upon not listening, not following instructions, doing what they want instead of what the adult in the circumstance wants. Attributing choice and intention to involuntary symptoms damages the person who lives with those involuntary symptoms. And lastly, on our list of cons is that it limits access to therapeutic modalities that specifically address mental health. It limits access to the therapeutic modality for mental illness rather than mental health. I see some folks are raising your hands. I'm so excited that you are interested in making a comment or asking a question, but during our webinars, we do not invite people off to come off the mute or to turn on their cameras. So if you have a comment or a question that you would like to make, please put it into the Q&A. My colleague, Jennifer Sevick, who is CMHRC's clinical director, is monitoring the Q&A, and she is responding, and she will hold anything that's really pressing to the end so that we can discuss it together in the live Q&A. But for now, please don't raise your hand. Go ahead and put those questions and comments in the Q&A. That's the perfect spot for them. Stigma is another important part of understanding the difference between mental health and mental illness, because stigma truly can be both external or internal. There is societal stigma that comes from misperceptions and assumptions that are made about an individual who has mental illness, but they're also internalized, that when the person with mental illness believes that stigma and directs it at themselves through judgment, expectations, and demands that may be unrealistic as a result of the mental illness that they are experiencing as involuntary symptoms. And so some of the assumptions that go along with mental illness are that people who have mental illness are violent. They're criminals. They are too dangerous to be around. There are also, well, I want to give an example of this actually before we move on. There was a Facebook community group that was based on geography, a community that was living in the same geographic place, sharing information about parks and community resources and new restaurants. Most communities have these. There was one in particular that was brought to our attention by a member of our community who was in this Facebook group, who reported that it was discovered that there was a group home for adults with mental illness within that community. And the other residents were up in arms. And they felt that it was wildly inappropriate that there should be a group home for mentally ill adults in their community that wasn't marked and labeled so that they could keep their children away from it. And I really wish I was making this up, but I was not. The member of our community who was part of that Facebook group spoke up and said, why in the world would we further stigmatize people who are just trying to live their lives? There was a lot of pushback and people trying to claim that people with mental illness are somehow inherently violent criminals who the rest of the population needs to be protected from. Perhaps the audience here at our webinar tonight recognizes the inappropriateness of those claims. You are, after all, interested in this topic inherently to begin with, but it is pervasive and it is common. And members of our community encounter this kind of stigma in their neighborhoods, in their community centers, in their places of worship, in their medical care facilities, doctors' offices, and hospitals. And it is something that can truly be significantly emotionally damaging to those who live with mental illness and their families. Other stigmas and assumptions that are made about people with mental illness are that they have poor relationships with others, that they are destined to be homeless, that they should be institutionalized, that taking medication to treat their illness is somehow going to turn them into a zombie, or that they won't feel like themselves. And perhaps most importantly, the assumption is that a mental illness cannot be managed and that it will not be something that the person can thrive while living with. All of these things are untrue. Perhaps each one of them may be true for a specific individual at a specific time. And I can imagine people saying, well, I heard about this person who did this violent thing, or my cousin's husband was mentally ill and he did. And yes, that's true. Stigma and assumptions and stereotypes often derive from some kernel of truth that is exaggerated and extrapolated to be representative of an entire group of people, even when it is not accurate on a broad scale. So these are some of those stigmas of mental illness. And I want to share one other story about the negative impact this has, because this is a story from our community again, of a family with a child who was in middle school. And the school counselor I wish I could explain why, but the school counselor took it upon themselves to share with another family that one of the children in the class had bipolar disorder. That child was ostracized, targeted for bullying, and his friends' parents found out that he had bipolar disorder, and those children were not allowed to play with him anymore. This is a devastating effect on kids, on teens, on families, when the bias against the mental illness causes them to lose their social network. And we'll talk more a little later about why that isolation can be so damaging. We do have to ask ourselves, though, when we start off talking about the commonalities between physical illness and mental illness, would we ignore the needs of people who are living with physical illnesses like cancer or asthma or diabetes or some other physical illness in favor of focusing on the needs of the people who catch a cold? Imagine if a breast cancer awareness campaign was shut down in favor of a common cold awareness event. It wouldn't make sense. We would all recognize that that was backwards. When we focus on the mental health to the exclusion of mental illness, or we give in to stigmatized belief systems about those who live with mental illness, everyone loses. This is especially impactful on children and teens because early intervention is the best tool that we have to promote long-term positive outcomes. And so when these children and teens get left behind in favor of mental health concerns, what we're really doing is we are putting them at tremendous risk. Now, the research shows us that in children and mental illness, that roughly 50% of mental illness begins before the age of 14. Fully half of all mental illnesses begin before age 14. And 1 in 5, that's 20% of children ages 3 to 17 have a diagnosed mental, emotional, or behavioral disorder, and that doesn't include all of the ones who haven't been diagnosed yet. There are 3.4 million children and adolescents who are diagnosed with major depression in the United States. And between 2016 and 2020, the number of children aged 3 to 17 who were diagnosed with depression grew by 27%. And yet estimates from research experts show that roughly 1/3 of all children and teens who are diagnosed with depression actually have early onset bipolar disorder. The research also shows us that just between 2018 and 2019, 15% of adolescents aged 12 to 17 had a major depressive episode. 37% had persistent feelings of sadness or hopelessness, and nearly 20%, again, 1 in 5, reported that they seriously considered suicide. So if we're looking at a 12-year-olds, that's a 7th or 8th grade classroom. A 7th or 8th grade classroom may have 25 or 30 students in it. Now imagine we have fully 20% of them. 4 to 5 of those kids in that classroom have seriously considered suicide. In adolescent girls aged 12 to 17, there has been a sharp increase and sustained increase in depression cases in the last 16 years. And mental illnesses are commonly co-occurring. In 2018 to 2019, among children with a current mental health condition, i.e. mental illness, more than 1 in 3, or 37% of them, had 2 or more conditions that were happening at the same time. The research also shows us some pretty stark figures when it comes to access to treatment. That among adolescents aged 12 to 17, the percentage who received mental health services in a specialty mental health care setting, i.e. an inpatient unit or an outpatient care, in the past year increased from 11.8% in 2002 to 16.7% in 2019. That is an enormous increase in a relatively short period of time. Over that same time period, the percentage who received mental health services in a general medical setting in the previous year increased from 2.7 to 3.7. And the percentage who received mental health services in an education setting in the past year increased from 12.1% in 2009 to 15.4% in 2019. These numbers may sound small in the abstract, but what we're talking about is real people, real kids who are in need of help and in many cases aren't getting it. Because when we look at access to treatment statistics, we see that the treatment onset delay for a child or teen averages a staggering 10 years. There is not a single state in the country that currently possesses even an adequate supply of child psychiatrists, and 43 states are experiencing a severe shortage. 22% of children who live below the 100% of the poverty threshold had a mental, developmental, or behavioral disorder. And age and poverty level negatively affected the likelihood that children would receive treatment for anxiety, for depression, or other mental illnesses, when with younger and less affluent children receiving less treatment. When you juxtapose this against the prevalence statistics that we just talked about, you will see that this is an unacceptable lack of access to treatment. And this issue of treatment access delay has been at the intersection of mental health and psychiatric law over the past few decades. And it has seen a significant increase in attention to mental health jurisprudence and the preservation of human rights in the context of mental health care, access, and treatment. Authors of a December 2018 article titled "Treatment Delayed is Treatment Denied," which was published in the Journal of the American Academy of Psychiatry and Law, states that of considerable concern, however, are those cases in which rote procedural approaches produced unintended consequences for the very persons such maneuvers were designed to protect. Delays may ironically lead to an acute illness becoming chronic, to a single bout of inpatient services being transformed into a lifetime of revolving door psychiatric admissions. It deprives patients of the liberation from illness that is the common goal of all stakeholders. This absolutely 100% applies to a child or teen whose providers have decided out of hand that they must have some mental health challenge that can be quickly band-aided with cognitive behavioral therapy, insurance covering 8 sessions, and sending them back on their way, when the reality is they are experiencing the acute symptoms that are involuntary of a mental illness. And being able to differentiate them is a crucial piece of being able to, as I said, provide the accurate early intervention that leads to positive outcomes. Because as I said, and as we all know, the risks are just too high. Increased risks of untreated or undertreated depression include suicide, anxiety disorders, substance abuse, heart disease, diabetes, sleep disruptions, chronic pain, premature death, and lower quality of life. The increased risks of untreated or undertreated generalized anxiety disorder include many of the same things in a slightly different order. Sleep disruptions, chronic fatigue, irritable bowel syndrome, migraines, chronic pain, social isolation, suicide, drug and or alcohol abuse, and again, impaired quality of life. You'll notice on these lists, there is a mixture of both physical as well as emotional effects. When it comes to bipolar disorder, which we at Children's Mental Health Resource Center really specialize in, we can give you some even more detailed statistics on these risks. The lifetime prevalence rate of substance abuse disorders with bipolar 1 is 40%. That means 40% of people with bipolar 1 will go on at some point in their lives to experience a substance use or abuse disorder. That number is 20% with bipolar 2. Better? Yes. But good? No. Bipolar has a chronic course of the illness that is associated with markedly elevated premature mortality, often through suicide. Approximately 10 to 30% higher is the suicide rate amongst those with bipolar disorder than in the general population. 20% of mostly untreated bipolar disorder subjects end their lives by suicide, and 20 to 60% of those with bipolar disorder attempt suicide at least once in their lifetimes, and bipolar disorder has the highest suicide completion rate of any mental illness. Now, we've talked about these risks in terms of untreated as well as undertreated. And that's an important distinction to make. We all know what untreated is. It's that treatment delay. It's those 10 years where no services are being provided, where there's no access to treatment. But undertreatment is also a concern. So when most people think about mental health treatment, they think about things like cognitive behavioral therapy or more traditional talk therapies of some kind. And when they think about mental illness, they tend to think about medications. But the way we think about treatment is much more holistic. We liken it to a three-legged stool because truly effective treatment, the kind that we need to achieve in order to maintain stability for a mental illness, includes three pillars: medication, therapy, and lifestyle interventions. We call this the three-legged stool of treatment because without one of its legs, a three-legged stool will fall over. And without one of these pillars, treatment is likely to be less effective and or completely fall apart. So medications are the first leg of that stool. And so we're going to quickly talk about some basics about medication. Medications need to be destigmatized. We need to recognize that medication needs to be accessible. It needs to be affordable. We need to accept that for severe mental illnesses, multi-medication combinations are often necessary, that it is not a characterological flaw to need a medication in order to treat a mental illness. Being on more than one does not mean that someone is less worthy of a human being than someone who's on only one or none. Side effects need to be considered, and risk to benefit analysis needs to be done on the medications that are being used rather than simply offering them or not based on a personal preference. The next type of therapy treatment is psychotherapy. This is where you need to be with a provider who's experienced with treating, say, mood disorders or whatever mental illness it is the person chronically struggles with. Seeing someone who only focuses on adjustment disorders, difficulties during life transitions, or life coaching is not the same thing as seeing a provider who specializes in a mental illness. It's also important, if you are having the person being seen in this therapy, a child or a teen, that the provider knows how to recognize symptoms of these mental illnesses in children and teens and are disinclined to write everything off as a phase. It's important to also be able to differentiate involuntary symptoms from voluntary behaviors. And you need to be engaged in some type of therapeutic treatment or psychotherapeutic treatment that focuses on rapport building, not skill development. Because if you remember, to go back to the beginning when we were talking about mental health versus mental illness, mental health challenges often involve the person being able to learn new skills and apply them. That is often not the case when it comes to an involuntary symptom of a mental illness. Providers also need to know when to use traditional therapeutic interventions, such as family therapy and individual therapy, and a remembrance that when you are dealing with mental health challenges, very often working with the individual themselves is sufficient. But when dealing with a mental illness, very often therapy and intervention for the entire family is required. The last leg of this stool, which is just as important, are lifestyle interventions. And lifestyle interventions are things that are low risk, high reward, that can be implemented at home without a doctor's prescription, but that can be done in a way that empowers the individual, that they are taking some ownership over their illness and that they have some way to act on their own behalf. And so lifestyle interventions include things like light therapy, cooling strategies, and metabolic therapies, which include sleep routines, food plans, as well as exercise. Now, most people are pretty familiar with light therapy, blue light exposure, blue light blocking. Most people are pretty familiar with cooling strategies now. If you've been around the CMHRC block for a while, we talk about cooling strategies as a way of proactively or correctively addressing temperature dysregulation as it may be associated with mood disruptions. And you may not yet have heard us talk much about metabolic therapies. We can all recognize the importance of exercise, but food plans are something that's extremely important for us to talk about. And so when we think about metabolism, mood, energy, we want to start off by understanding that metabolic health is mental health, and that there is decades of scientific evidence that suggests that mental illnesses are rooted in a systemic metabolic dysfunction that is affecting the brain. Neuroscience shows us that the metabolism of the brain is impaired in people with mental health disorders and illnesses, and that improving metabolic health and metabolism in the brain improves and reduces symptom presentation. Metabolic psychiatry is a relatively new field, but it is rapidly emerging to help put symptoms of mental illness into remission. And there are metabolic strategies like ketogenic therapy, like circadian rhythm resets that are emerging as promising new treatments for psychiatric disorders, for improved brain health, and for overall improved quality of life. Now, we at CMHRC are doing a lot of work connecting with folks who are world-renowned experts in metabolic therapies. And so we want to share with you these resources about metabolic treatments for mental illness. And that includes Dr. Georgia Ede, who's a world-renowned psychiatrist who is one of the first to begin using metabolic therapies in order to treat mental illness. She has written the book, Change Your Diet, Change Your Mind, which you can get and read. We also have a webinar that we did with Dr. Ede last summer that you can find on our YouTube channel. We also have connected with Dr. Chris Palmer, the author of brain energy. Again, a book that you can get and read. It is fascinating and goes into the science of metabolic therapies in more depth than Dr. Ead's book, which is a much more practical guide. There's also Beth Zupek-Kania. She is a registered dietitian and the author of the Modified Keto Cookbook, ketogenic therapy being one of the key metabolic therapies that is used to treat mental illness and such as bipolar disorder and other mood disorders. And Denise Potter, also a registered dietitian. She runs the Advanced Ketogenic Therapies, which you can find their website online by Googling her name with Advanced Ketogenic Therapies, with all kinds of tools to help people learn about and implement ketogenic therapy and other metabolic therapies. The Metabolic Mind is a organization that we have partnered with in the past. We did a clinical seminar, last year with their medical director, Dr. Brett Scher, who is a cardiologist and uses metabolic therapies in his patients to treat mental health challenges and mental illnesses. And we very much encourage you, if you have questions about metabolic therapy, to go to metabolicmind.org and do some reading. And then we have our very own Ketogenic Therapy in Action program. It is running currently as a research study where we are gathering information on the effectiveness of a ketogenic therapy in the treatment of bipolar disorder in children ages 6 to 17. We look forward to sharing the results of that study with our community later this year. All right, there's one other lifestyle intervention, if you will, that is very important for us to talk about, because and folks may not recognize this when I first mention it as a lifestyle intervention, but it really is. Too often, parents are blamed for the mental illnesses that their children have and for the involuntary symptoms and signs of that illness that their children display. And when we at CMHRC talk about mental illness in childhood, it is devoid of any blame on parents for their child's illness, even when we think that that illness may be hereditary. If a parent has an illness and passes it to their child, it still doesn't make it that parent's fault. And so we find that, unfortunately, many parents who are engaged with the mental health care system, with the physical health care system, with educators and educational systems, often, and I don't mean to badmouth any of these providers because they are doing what they truly believe is best and are well-meaning, but they're inadvertently blaming the parents. And so our focus at CMHRC instead is on empowering parents. But we recognize that this is a huge struggle for parents of children who have mental illness, because the truth is that parenting strategies for neurotypical children just don't work for kids who live with the involuntary symptoms of a mental illness. And so through a new approach that we teach, which we developed, which we call palliative parenting, I'll just say, for the record, it does work with neurotypical kids, but those neurotypical interventions don't work with kids who have mental illness, and palliative parenting works with both. Palliative parenting was actually designed specifically for parents of children living with mental illness, and it was designed in collaboration between mental health professionals, parents of children living with mental illness, and adults who had the lived experience of having mental illness while they were children. And it starts from a completely different premise. The premise that we work is that, as I mentioned, we don't blame parents for their child's mental illness. We don't blame them for their child's symptoms. We don't blame them for what other people call the behaviors that go along with mental illness. Palliative parenting rejects the formulaic strategies that suggest that kids with mental illness somehow need to be fixed or cured. We recognize that those children are whole human beings of great value with or without a mental illness. We focus on changing the parent's perspective, their thoughts, their feelings about mental illness, because in turn, that changes the way they interact with their children. And the primary tool of palliative parenting is the parent-child relationship and the interactions between them. That is the tool for positive change in palliative parenting that empowers parents to understand the symptoms of the mental illness that their child lives with and the impact of those symptoms, to see those symptoms in the moment when they are happening as involuntary symptoms and not intentional behaviors. And it empowers parents to address those symptoms in ways that promote positive change while validating the child's lived experience and rejecting punishment and, the modern terminology for punishment, which is consequences, and rejecting that as a model for being able to teach children how to manage the illness that they live with. Palliative parenting focuses on a three-pillar framework. Again, that three-legged stool, not of treatment, but of parenting, and that is of acceptance, respect, and community. And embracing all three is what's necessary to help us make those positive changes. And so in acceptance, we're able to really look at our children objectively and accept the fact that they have different needs. And as a result, we're going to parent differently so that we are meeting those needs. We are letting go of pre-existing expectations, and that our goal is accepting our children for who they are, accepting ourselves for who we are, and working to improve our daily lives together, to improve the quality of life that our children and our families experience. That second pillar is respect. And here we're talking about respect that is rooted in the simple truth that, as I mentioned, our children are human beings first. They are not the sum total of their mental illness. They have their own journey. They have their own hopes. They have their own experiences outside of those of ours as a parent. And they are not merely a reflection of ours. They are their own and they are independent. And we respect our children for their unique individuality, and that we aspire for them to have, again, the best possible quality of life. And that third pillar of palliative parenting is community. Our children make positive contributions to the world and can be a part of it. And that means that we are advocating for awareness, acceptance, and accommodation for our children that are appropriate to meet their needs. We're honest about our own and our children's strengths and weaknesses, and we facilitate collaboration among our children's support systems. We share strength, knowledge, and hope within our community. This is embedded in all that we do at CMHRC because we recognize that isolation is dangerous. Within isolation, self-doubt, guilt, negativity, burnout, and self-harm can grow and fester. One parent in our community emailed us recently with this message. My children live with trauma, autism, ADHD, bipolar, and anxiety, which is so isolating for us. On the really hard days, CMHRC gives us the community of parents I had been longing for. Socially and emotionally, CMHRC is a lifeline, sharing the knowledge, compassion, and grace with a dose of humor, I appreciated that, that I need to continue living this life fully. And so the tagline for our organization, Children's Mental Health Resource Center, was, and always will be that you're not alone. We're here to help. And hopefully, by understanding the differences between mental health and mental illness, understanding what the stakes are for our children as they grow, understanding what the best treatment involves, and knowing that you are a part of a community that supports you as a parent and can give you the tools that you need to parent your unique child with a mental illness, you will recognize that you are not alone and that you are on the path to recovery. So thank you so much for being here with us tonight. These are the works cited in this presentation. There are a lot of them. And if you're interested in getting a copy of this slideshow that went along with this presentation, you can request a slideshow for a $25 preparation fee, and you will be able to have access to all of these resources. Once again, it's 2025, and at Children's Mental Health Resource Center, we pride ourselves on being able to offer as many programs free of charge as possible, so the providers and families they work with have access to the guidance and resources we have to offer. It is expensive, however, and so we ask that if you have taken advantage of any of those free resources, that you make a contribution, either a one-time gift of $25 or a recurring gift of $25 in 2025. And again, you can use this QR code to take you to our safe and secure online giving platform where you can make a gift today.